Your conventional or your first generations. These are the ones we talked about that target just the dopamine and just those positive symptoms, the hallucinations, the additives, the things we didn't have before. A benefit of this group of meds that have been around for a while is they are less expensive. And if you can manage, if they're being closely monitored for those bad signs and symptoms, that's definitely an advantage. The negative is they don't treat the negative symptoms. Remember the personality changes, the blunted affect, the kind of just not happy with life, the hopelessness and all. This conventional or first generation does not target those signs and symptoms. And then again, it comes up again, they do though have those risks for these side effects, extrapyramidal and the tardive dyskinesia, those are controlled by somebody. Anticholinergic side effects, what are those? That just bothers people, you know. So you want to make sure you're teaching about it in ways they can treat. And so those extrapyramidal side effects that we were talking about from the conventional or first generation antipsychotics, the acute dystonia, and it's a twisting movement, writhing type movement, akaesthesia, I can't say that, I can't sit still, pseudo-Parkinsonianism, the gait issues, it kind of mimics Parkinson's disease. Yeah. Now, these are the red flags for this group with antipsychotics. Neuroleptic malignant syndrome. If you look on page 217, this is all in your book. And this is from the increase in the dopamine blockage that you could end up with one of these life-threatening responses to the antipsychotics. With the malignant syndrome, the big key is elevated temperature and all. They could end up being in ICU. These are very sick. With the agranulocytosis, you want to make sure you're teaching them to report to their doctor any signs of an infection. Sore throat, fever. So you can go over, these are key. Make sure you know the signs and symptoms of these two and what you would teach your client to watch out for. Page 217 in your book. Now, other meds that we can give, we've already mentioned these, antidepressants, anti-manics. You can look back into your bipolars, but they're not as important as the antidepressants. We'll go back to your book and show you a couple of things. It'll be good when you're studying. You look on page 212. Before I get to that then. All right, so we talked about the hallucinations and the delusions. This is a really good box for when you're studying and with your communication skills. But if you have somebody that's hallucinating, these are just some good tips to go over for things that you can say with the hallucinations. You can just ask the patient directly, what are you hearing or what are you seeing? and you watch your client for signs that they're having hallucinations, and you can see this sometimes just with people out in public. You know, they'll be talking to something and they don't have a phone in their ear or something, and they're obviously talking to someone who's not there. Or you can see their eyes drifting across and you can tell that they're watching something. And so monitor your client to see if they are having it. Avoid referring to the hallucinations as if they're real. You know, you don't have to argue with the client or anything, but you avoid contributing further to the hallucination. Focus on reality and the here and now. A lot of times this is really scary, obviously, so you can say, you know, I understand this is scary for you, but I need you to kind of concentrate on me right now and try to listen to me instead of the voices. Be alert for anxiety that may be increasing with the client, because that agitation, that increased agitation and anxiety could indicate that the voices are demand hallucinations, telling them to do something that they shouldn't do, or their anxiety level is up so much, the pacing, that all it could lead to violence or could lead to them hurting themselves, and monitor that. And you also, long term, you kind of watch the hallucinations and try to match it with how their emotion was when they were having that hallucination, and you might can kind of understand what there may be some links or some patterns. So anyhow, I wanted to make sure y'all looked over that, and let's see, there's also one that's good for delusions. Okay, so the delusions, these are those fixed beliefs that they have. So first you want to build trust with the client. Be genuine. Talked about that in Unit 1. Respond to suspicion in a matter-of-fact, empathetic, and supportive manner. You know, I kept walking past room 14 down there, and every time I go by there, they're plotting to kill me. Those two patients down there, they're coming up with a plan and they're going to kill me. That patient has to trust you, so you had to have built some sort of a rapport with the client. And a good response would be, well, I can see that's upsetting you, and you want to explore it a little bit further. And tell me more about somebody trying to hurt you. Instead of now going back to your room, there's nobody in down the hall trying to kill you. You see how that's not the correct response. Avoid debating it. And you know, now we're not going to get this creative, but, you know, you may want to interject some doubt. It seems like it might be hard for that little girl to hurt you. You could get a little bit of doubt in there. Tell me, it seems like it might be kind of hard for those two patients down there to hurt you while we're all here. That's appropriate, but don't worry about it. Going back down there, we ain't going to let that happen. That's not appropriate. Focus on their feelings that seem to come from these delusions. Maybe they're scared or feeling powerlessness. And then it does mention that once you've established trust and a good therapeutic relationship, you might want to say something like, it seems very real to you, but I need to let you know I don't see that. It's not true to us. So those are just some good boxes for you to use when you're studying. And when you get into this PowerPoint, it talks about the different kinds of schizophrenia, like the disorganized and the catatonia. You don't need to focus that much on that with your syllabus. Okay, so you mainly need to understand it just in general for schizophrenia, not break it down into these different types here at the end of the PowerPoint. You know, the undifferentiated types. So just keep that in mind when you're studying. A couple of other things. On page 214 in your book, also, it goes over associated looseness and how you deal with the client when they're talking like the client was in the video. It's a little bit further on, but you don't pretend that you understand them. You don't, oh yeah, that makes perfect sense. Don't do that. You want to try to look for themes in their what they're saying. It could be very disorganized and all, but you could pick up some things in what they're saying. And you want to reduce their stimuli. If they're really, really disorganized and their thoughts and their words are really disorganized, you want to make sure you're not having them out in the day room trying to play bingo or something and it's really getting them upset. And also page 215 in your book goes over the meds really good, especially those first generation meds. Now, one thing with the hearing voices, with the positive symptoms, with the schizophrenia, we talked about reality testing a little bit, but reality testing is helping the clients to differentiate if what they're seeing or hearing is real, trying to teach them that skill set to try to understand. And one thing that you can teach the patients and their family can help with them is to kind of get them in touch with reality is they're having hallucinations, they're hearing voices, or they're seeing things. One way they can kind of test reality, is this real? Is what I'm seeing real? Is look at others in your family or other people and see if they're hearing what I'm hearing or seeing what I'm seeing. They may get to where they can even ask people, did you hear that? Especially you as a nurse, they'll ask you, did you hear that? And you're like, no, I didn't hear what you heard. Tell me what you can tell me what you heard. And then you kind of teach them, if other people aren't hearing it, and you've tested reality and this isn't real, you can safely ignore those voices and what they're saying to you. So you see that process they have to go to. This is also right along in the same place where we were looking at the skills on how to talk to them when they're having hallucinations and delusions. Some other tips you can teach them too is they can talk to themselves. Try to drown out those voices. Talk to yourself. Tell yourself those voices aren't real and that they're a symptom of my illness. Some other things they can do is engage in activity. Try to get outside, clean the house. You can listen. They also teach them maybe try listening to music. Anything to kind of try to help with those voices. Do something physical. Here are those tips for you all with associated looseness. Don't pretend you understand it. Put the burden on you, not them. I'm sorry, but I'm having trouble understanding what you're saying. Instead of, you're not real clear, can you tell me what you mean? Yeah, you see how you put it back on you. I'm sorry, I don't understand what you're saying. Another way. If you do understand something, go ahead and tell them. Oh, okay, I understand. Did I hear you correctly? I think you said you're upset about this. And then if they are, then that gave you an opportunity into all those thoughts that are coming out to maybe help them deal with their feelings. Reduce stimuli in the vicinity. Speak concisely, clearly, concretely to them. You want to be in a line of sight. And some you can try summarize. So those are some of the best, those are good, clear things that you can do when you're dealing with these type clients. Okay? So, let's go to sexual. y'all are able to kind of read and go over the stuff tonight, we can touch back on it again tomorrow. Okay, so let's do sexual disorders. This is chapter 20 in your book. Now, going over this unit, this information, sexuality is, out of everything that we've covered, the most personal and unique to people. So again, remember, when we're talking about this, we're talking in generalities. What may be acceptable for one person may not be for somebody else. And this is, so sexuality is on a continuum. I'm sorry, can y'all hear me okay in the back? I'm gonna sit for this a minute. Can you hear me? Good, okay, great. So sexuality kind of encompasses everything physical, chemical, psychological, functional characteristics that make up our gender identity and then sexual behavior, how we identify ourselves and the activities we do. On the continuum, on the one end is the adaptive end, where you have satisfying sexual behaviors and you respect others. Okay, so optimal functioning is you are able to identify yourself in a way that is healthy for you, and the activities that you take, that you do sexually are pleasing to you, and you're not hurting yourself or others. Okay, so that's just a good way of summing that up. And then on the other end, the maladaptive is sexual behavior that becomes impaired and dysfunctional, usually to the point of someone's hurt, or emotionally or psychologically you are not fulfilled because of the sexual activity. And this is one of our smaller chapters in the unit, so we won't spend as much time on it as the others. Again, 20. Okay, so sexual disorders cause distress, and they cannot, the problem with the sexual disorders is it may not just be impacting the client, it could be impacting others. They could be hurting others with their sexual behavior. It can also lead to socially inappropriate or illegal activities. So sexual disorders or problems are where someone is being hurt, not fulfilled, and you could end up in jail. Okay. So sexual dysfunction, though, is a disturbance in some part of the sexual cycle. Okay, desire, excitement, the ability to have an orgasm, and resolution. Those are the 4 stages of sexuality cycle. And so when we hear people talking about sexual dysfunction, you're talking about some sort of impairment in one of those 4 areas. Disorders are where someone is being hurt, you're hurting yourself, you're doing something illegal or socially inappropriate. So most of these we're familiar with. Your gender identity is how one views your own gender as either masculine or feminine. Sexual identity, female, based on that's our actual biologic makeup. And sexual orientation is who we are individually attracted to, gender-wise. Heterosexual expresses sexual feelings for the opposite sex, and homosexuality for the same sex, bisexual for both. sexual behavior, how you respond to sexual impulses and desires. Transgender, individuals whose sexual identities are entirely with the opposite sex. A transgender person's gender identity doesn't coincide with birth gender, and the individual can be bisexual, homosexual, or heterosexual. Transvestite is a person who derives sexual pleasure from dressing or masquerading in the clothes of the opposite sex, commonly called cross-dressing. Sexual dysfunction involve impairment of the cycle that we just talked about. And then paraphilia is the actual name of the disorders, and that is recurrent, intense sexual urges and sexual fantasies that are generally around a non-human object. Paraphilias, and we'll go over that a little bit more. Okay, the theories, we always kind of hit the theories in the background. There's a thought that biological theories explain our sexual variations to do with like our chromosomes, our genetic makeup, that contribute to our tendencies, our traits and our preferences. Psychoanalytic theory, of course, this would be more like your Freudian approach. This is that any sexual variations that we have and tendencies stem from some neurotic and psychological developmental problem that we had. Something happened earlier in our life that contributed to this behavior. And then the behavioral theory is that most modes of how we sexually express ourselves are learned behavior. That as we grew up, we learned these behaviors, and that's where our tendencies come from. And as with most things, though, our sexuality is probably a combination of all of these. Our genetic makeup, biologically, what's going on with us. Things that happened to us when we were young, and then traumatic events that may have happened to us, and then learned behavior from a relationship or from family. Normal sexual behavior is generally what's accepted by society that you're in. But the overarching normal sexual behavior is that it takes place without any force and is performed in a private setting in the absence of unwilling observers. That's normal. Abnormal, any act that does not meet the above criteria. And these can be influenced by cultural and ethnic factors, religious views, your health status, age, personal choice. Okay, so our standards for nurses when we're working with clients working with them about anything to do with human sexuality. Have respect for your client, obviously. This is one of those situations you have to examine your own feelings and maintain a non-judgmental view. Everything we kind of talked about in Unit 1. You're going to be in situations where you're having to ask questions and take care of clients in situations that may be uncomfortable for you, or certainly uncomfortable for the client. And if you're asking questions that are very private, it helps to explain why you're asking. And if they have concerns with confidentiality, you always remind them that we are bound by confidentiality, and especially when you're just talking about their normal sex life. We're not talking about a sex life. I've done that part. But remind them that this is private, and that I'm an RN. I'm a professional, and you behave that way. If you feel uncomfortable, you just remind yourself, this is my job, and I have to do it. You approach it in a professional manner. Dysfunctions with sexuality can happen at any point in that cycle. Problems with arousal, the desire to have sex, the ability to have an orgasm. They may have pain when they're having sexual intercourse, or they could have sexual dysfunction from a medical condition, and that is one of the bigger issues we see today. So your assessment needs to look at all of those things: age, health, do they have a diminished libido or desire for sex? What type of lifestyle things do they have going on that could impact it? Then you could assess, do they have some sort of aversion to it? Do they have anxiety or fear that is interfering with their sexuality? Some of the things that can interfere with arousal, it may be psychological, or it could be cardiovascular disease, cigarette smoking, diabetes. Those can all impact sexual arousal. So you have to assess good medical history. If they have a problem with orgasmic disorders, unable to reach an orgasm, usually with women it's the psychobiological factors. They may have like a fear of rejection, maybe afraid of getting pregnant. They could have hostility towards men. There could be a lot of psychological issues going on with why a woman has an orgasmic problem. They may have guilt feelings. With males and an orgasm with premature ejaculation, it's usually happens before they wish it to, and it's out of their control. Yeah, what time is it? Early when we squeeze it. Yeah. We'll finish it up. I'm sorry. I don't know about y'all.